It's interesting. Do you still find a lot of resistance to learning the new advanced tools and techniques for limb salvage, in particular, treating those smaller vessels in the calf and the foot?
Well, specific patients with foot arteries with isolated foot artery disease are not so frequent. We have many of the since we treat diabetic patients with diabetic foot. I can say there is a resistance. What I can imagine or what I can face every day is there are a group of people that really believe in the treatment of those patients, that really believe that those patients need a treatment and that we can succeed and we can provide a better outcome and a good result for those patients compared to other ones that they refuse to believe because probably they are not able to do this type of procedures as well. They cannot manage 360 degrees all the situation of those patients. But I cannot imagine about the resistance, just people that since they are not able to manage those type of patients, they decide to refuse the therapy for itself.
Do you find that taking place in Italy as much as we do see that here in the States and in a lot of areas of Europe?
Yeah, it happened everywhere around the world, I believe. It happened even in Italy, in which a country in which we have many physicians dedicated for CLI and for diabetic foot. And most of the vascular community in Italy know that we are dedicated for that. But even though we receive many patients with for second opinion, with first opinion, that was amputation, even if many other colleagues know about us. So yeah, it happens. It's normal. It's the same situation even in Spain. That's the reason why I'm a bit moving to that to help colleagues to grow. And yeah, we receive many patients with a very late diagnosis, people that have been looking for a second opinion since the first opinion was amputation.
What do you think it's going to take for a meeting of the minds on both sides, those who do believe in treating below the knee and into the foot versus those that don't believe in treating below the knee and into the foot, when they're continuing to say, well, show me the evidence, show me the evidence. And in my experience and in my opinion, some of the folks that are participating in some of the studies that are arguing for the limitations of the doctors that believe that they should not treat below the knee and into the foot, the ones that are part of those studies are not the ones that should be participating because they may not have the advanced skills to be able to do that. They haven't done as many successful procedures as in your case or in your partner, Dr. Marco Manzi's case, or in this small community of so-called CLI fighters who perform these on the daily basis with so much success.
Well, yeah, starting from the last part, we perform this type of procedures on the daily basis. I did 5 procedures of this type today before to meet you. I think, yeah, for sure, science is science, but not always is a real world. Let's say if some people
Well,
that
it's only as good as the doctors that are participating. And as you know, not everyone has the same skill set just because they have the title of doctor. And I'm saying that doesn't mean that they have the right skill set for every single situation.
Yeah, exactly. I fully agree with you. In fact, I'm dedicated for diabetic foot because I'm not able to do any other thing. So anyone must to dedicate to some specific things and speak about what is their a specific topic or this specific treatment strategy or disease management. For sure, there is a lot of resistance in the group of the no believers, and they push too much to say that well, it's so expensive, the results are no guarantee and so on. But finally The evidence today is not so big, but we have evidence that allow us to show, and evidence from US as well from other countries around the world that show us that finally we reduce amputations, we increase the quality of life, we reduce death related to amputation, and we can finally improve the quality of life as well for the patient as well for the families. So I think for those no believers today, they need to start to think about something different, because the evidence actually available support the endovascular treatment on the revascularization, even in some cases in which it can be performed by surgery. The evidence supported the revascularization strategy in CLI patients.
And I think we're going to see this movement from patients, because even today I ended up with Douglas here, who had a question right along those same lines. And I thought, wow, the patients are getting smarter and smarter and smarter, and they're going and doing their own research, and they're actually finding those YouTube videos, and they're finding the studies. And I get asked almost every day about pedal loop revascularization, as if it's like this new grand, aha, whoa, this is amazing. And, hey, do you have a doctor that does this loop procedure? And even Deborah, who's in our live studio audience, had actually kind of be, Kim, there's this new procedure. It's called the loop procedure. I'm like, yep, it's been around for a while. We just got to get more doctors doing it.